All right. So Dr. Andrew Kim here. I'm a board-certified psychiatrist. I decided I was going to just kind of spend some of my extra time tonight live streaming and kind of redoing a topic I just gave a talk on a virtual class education session in collaboration with NAMI, the National Alliance on Mental Illness, and a lot of people seem to find it helpful. And basically what we're going to do today is a general overview of some of the most common FDA-approved treatments for major depressive disorder, or MDD. Most of us kind of better know it as just clinical depression. We don't have time to go over every single treatment, FDA-approved treatment that's out there. So I'm going to try to break these live streams into different chunks. And today we're going to focus mainly on the most common type of prescribed treatment, which are selective serotonin reuptake inhibitors, which are known as SSRIs. These are like your Prozacs and Zolofts and Lexapros of the world. And, another group similar to that called SNRIs, or serotonin norepinephrine reuptake inhibitors. So, we're not going to jump into like the neurochemistry and biology of what chemicals are being released or what's happening, at the nerve cell level, but more like practical tips of what to expect if you are going to potentially take these, in terms of like when to expect positive results, what are the chances of positive results, what are some of the side effects you need to be on the lookout for. So these are the types of things we're going to go over today. In terms of anyone who joins this midstream, as long as the recording goes okay without any interruptions, I'll probably just leave this up on my playlist as well, so people can kind of catch it and watch it later. But in terms of questions, feel free to throw questions in the chat box. Again, I'm not your doctor. I'm not your physician. This video is meant for informational and educational purposes only. So I can't answer personal medical questions, but general topics, general questions I can get around to. And yes, if you leave some questions, I will kind of get around to them maybe 20 minutes in when we kind of take a break. So before we, go any further, let's just kind of go through a couple of, disclaimers and whatnot, disclosures. So I am a board-certified psychiatrist. Again, I'm not your physician. This is for information and educational purposes. I've worked as a research investigator, which is basically the lead physician that takes care of patients during clinical research studies. For numerous pharmaceutical companies. I'm also on the Speakers Bureau as like a public speaker that's paid for Janssen Pharmaceuticals, which is a small subsidiary of Johnson & Johnson. So with all that boring stuff out of the way, why don't we go ahead and get started? So, before we even talk about the SSRIs or the antidepressants, let's just do a brief overview of what we're talking about when we're using that term major depressive disorder, or MDD. And I'm not going to belabor this too much, because you can go on Google and you can pretty much find lists of these anywhere with bullet points and checklists and whatnot. So we'll just kind of go through this as quickly as possible. So the important concept to keep in mind is that just being sad or chronically having a low mood, that doesn't necessarily equal what we call major depressive disorder, or MDD. We call this clinical depression. There are different types of depressive disorders. Okay, there are things like what we call persistent depressive disorder, which used to be called dysthymic disorder. There is chronic depression related to chronic substance use, like chronic alcohol use disorders, opioid dependence. Depression from medical issues like uncontrolled sleep apnea, chronic pain issues. So the important thing to keep in mind is that, the treatments we're going to be talking about, they were designed specifically for major depressive disorder, or MDD, okay? So let's just go over the concepts of MDD real quick. So the criteria we're going to review is from the DSM, the Diagnostic Statistical Manual of Mental Disorders. It's kind of the diagnostic book or guide that we use as clinicians to kind of help us make diagnoses for patients that we're taking care of. So we're going to go through this list quickly. You have to have at least 5 of the symptoms that I'm about to read off. Okay, at least 5 for at least 2 weeks or longer. And they need to cause problems or impairments in your functioning. So whether that's screwing with your work life, screwing with your academic or school life, your personal life, your social life, it's got to not only be present in terms of the symptoms, but be screwing with your functioning somehow, all right? One of the 2 symptoms has to be either depressed mood or loss of interest or pleasure. So one of the symptoms has to be one of those 2. So the first one is kind of the most obvious one is depressed mood, but the key here is it's most of the day and for most days of the week. So we're not talking about an hour here, 20 minutes there, but pretty much, week to week, you're saying, I'm pretty low, I'm pretty sad, I'm pretty down, feeling hopeless for, much of the day and for most of the week. The second one, which I already mentioned, is your interest level, pleasure in things, in your activities, in your relationships, your hobbies, way down, okay? And there's a distinction to make here. It's not, I can't go do these things because I'm too tired to or I don't have the opportunity. Like right now, we're in the middle of a pandemic, so obviously there are things you probably can't go do because they're closed or there's no access, but it's really more about that interest. Do you still have that interest and can you enjoy things? The next one is big changes in your weight. So weight loss or weight gain that wasn't intentional. Okay, so it's not like you're dieting on purpose to lose weight, but you're losing weight, all right? Or you're not bulking up, trying to gain muscle, but you're gaining weight. Significant changes in your appetite, either direction. The next one is you notice that your thought processes, kind of your processing speed, how you're tackling your daily tasks and your errands is slowed down. Other people around you may notice this. Other people around you may notice that your movements are even more sluggish and slow. Okay, so that's the next one. The 5th one is fatigue or loss of energy nearly every day. Again, so most of the week it's present. That's a pretty self-explanatory one. The next one is feelings of worthlessness or excessive or inappropriate guilt nearly every day. Concentration issues is the next one. So that's trouble with reading, trouble with conversations, staying on task. And the final one is recurring thoughts of death, recurrent suicidal thoughts, behaviors, or even suicide attempts themselves, preparations for suicide. All right. Even though it's not listed as one of the main criteria, the other one I always add is that is anxiety, because I think most people who are going through clinical depression feel like their anxiety level goes up, whether that's kind of general everyday worrying or feelings of panic or like panic attack like symptoms. So I'd kind of throw anxiety in there as well, even though it's not officially one of the core criteria. All right. So that was, again, a brief overview of just what it is we're trying to treat with the antidepressants we're going to talk about today. Now, one concept I want to mention is that if we kind of buy into this concept of major depressive disorder or MDD, all right, in research, we actually believe that this is what we call self-resolving episodic illness, okay, a self-resolving episodic disorder for most individuals, okay? There's always exceptions. But what does that mean, self-resolving episodic? Even without treatment, okay? So no therapy, no meds, no antidepressants, but if you just said, tough it out, just sit there, tough it out. In general, these waves or episodes of depression actually will resolve for most people. On average, without treatment, it can take 6 to 13 months to resolve. So, do we want people to suffer for 6 to 13 months while we say tough it out? No, of course, that's a terrible thing to have to suffer for weeks or days, let alone months or years at a time. So that's why we step in and we try to do something, whether it's therapy, pastoral counseling, medications, all of the above, because we want to try to shorten the length of this depression and how it's screwing with your life to hopefully weeks or a couple months, not 6 months to a year long. So that's the reasoning and the rationale of why we're trying to step in with treatments, okay? So again, like I mentioned before, the reason I harped on that so much is these meds that we're going to talk about today, which we will in just a second, were designed specifically for this type of depression. Not some of the other kinds. It's not like we don't use them for the other types of depressive issues, but the best results and the results that we can kind of talk about today are from research specifically around major depressive disorder. So I wanted to preface it with that. So let's go ahead and get started finally with SSRIs and SNRIs. So again, SSRI stands for selective serotonin reuptake inhibitor. All right, SNRI just involves two chemicals instead of one, serotonin norepinephrine reuptake inhibitors. All right, so the first one kind of focuses on one chemical or neurotransmitter called serotonin. That's a chemical in our brain, and the other focuses on two chemicals, serotonin and norepinephrine. And we have this naturally already in our brains right now. So what is serotonin? What is norepinephrine? These are chemical signals that we have at this very moment as you're sitting there, and our nerve cells kind of, this is one nerve cell, this is the other, they talk to each other and they communicate to each other using these chemicals. So there's communication in our brains with electrical signals and these chemical signals. And serotonin and norepinephrine communicate, they're ways that the nerve cells communicate with one another. Now, we're not going to get into the biology and the chemistry of all of it, but one thing I want to mention is it's not as simple as just boosting your serotonin levels or your norepinephrine levels. It's not. These TV ads, these commercials, and honestly, even like the supplement industry, they love talking about this concept, boost your serotonin, boost your norepinephrine. It's not as easy as that, okay? Here's an example. If I pop the Prozac capsule right now, okay, if I pop one right now, my serotonin levels will go way up like in just a couple of hours, just like that, okay? This has been proven, this is fact. We've done these blood tests on people. But if I was suffering from clinical depression at this moment and I popped the Prozac and my blood levels of serotonin skyrocketed, would my clinical depression go away in hours? No, it wouldn't. That we know that doesn't happen. Or we would have we would have really just stomped out and cured clinical depression by now if it was simple as boosting your serotonin, okay? By changing how our brain is using serotonin and norepinephrine, this leads to all of these downstream effects. It's like a domino effect that causes changes to the nerve cells. There's actual physical changes that happen to the nerve cells, and this takes weeks, okay, weeks to happen. And that's why when we're going to talk about this, you're going to notice me saying that it's going to probably take 6 to 8 weeks to get the full effect from these antidepressants if they work for you, okay? So that being said, what are some of the most common SSRIs? You'll probably know them by their brand name or their generic name. Prozac, which is fluoxetine, Zoloft, which is sertraline, Paxil, which is paroxetine, Lexapro, which is escitalopram, Celexa is citalopram. Those are some of the most commonly prescribed SSRIs. Some of the common SNRIs, the ones that act on serotonin and norepinephrine, are Cymbalta, which is duloxetine, Effexor, which is venlafaxine, and Pristiq, which is desvenlafaxine. So there are way more than what I just listed. I mean, there's literally 20-some, 30 of these antidepressants, but in general, with a few exceptions, but the vast majority of antidepressants are some variation of an SSRI or an SNRI, okay? Now, one point I want to make here is I usually prescribe generic antidepressants literally like 90–95% of the time. So what is a generic versus a brand? Basically, when something is called a branded medication, that means the company who developed it and kind of funded the research to get it FDA approved, they have a patent on it, like a copyright. And they're the only ones who are allowed to manufacture and distribute and sell this. And as a result, because they kind of have a monopoly on it and they have a patent on it, they tend to cost more and are more expensive, meaning it may make it more challenging to access these medications. Generic doesn't mean worse. Generic just means that patent or that copyright ran out, and now other manufacturers and other pharmaceutical manufacturers and companies are allowed to make those same medications. They just can't call it like the brand name. They can't call it Prozac. Now they call it fluoxetine. They can't call it Zoloft, but now they call it sertraline. But essentially, it's the same chemical, but now multiple companies are able to manufacture it. And when that happens, you have competition, and that drives the price down. The reason that I'm kind of harping on this is I have a lot of patients who come to me and say, Dr. Kim, I don't want the generic one. I want the brand name Prozac, or I want the brand name Zoloft. And I tell them, I am not lying to them or trying to make them feel better. It's the generic antidepressants work just as effectively as the brand name ones. They're essentially the same med. It's the same active ingredient. So one point I wanted to make as a practical tip is there's no issue with being on a generic antidepressant, okay? And, for me, like I said, there's usually almost no reason, unless I specifically have to use that one brand medication and there's no generic available. I usually prescribe generics almost all the time because I want to make it affordable and accessible to my patients. And a lot of the pharmacies out there, they have at least a few generic meds that are very affordable. Like Walmart has a $4 list or a $10 list. Sam's Club, Costco, and I have a video on this so you could check that out. But that's one of the points I wanted to make. All right. Now, I'm not going to get into the specific dosing of what dose you need to be on for each one, because literally we could talk about each med for like a half hour to an hour. I mean, literally I can make an entire video on each med. I want to talk about some of the concepts now of when to expect results realistically, what are the chances of getting positive results, and what are the key things you need to make sure happen in order to increase those chances of success, okay? So look, if you are someone who is currently taking one of these or plans on going to take one of these, you need to be educated so that you can advocate for yourself. Or if you're a clinician out there who's going to watch this, and let's say you're kind of new to prescribing, you're not in psychiatry, you're in family medicine, primary care, and I know you guys prescribe antidepressants a lot. You're the #1 prescribers of antidepressants, but if you want to kind of fine tune the prescribing habits based off research, these are some of the tips you need to follow. So #1, whether you are the person taking this med or you're the person prescribing this, in general, okay, there's always outliers and exceptions, but in general, the dose of the antidepressant needs to be in a therapeutic range. It has to be a therapeutic dose, okay? Not every dose of each antidepressant is actually considered therapeutic, okay? That's why there's recommended dosing ranges from research and from the FDA, because we've studied this, okay? Not every dose works, okay? So you have to make sure that, again, that the dosing range is as close to therapeutic as possible. The second key point is you need to take it for an adequate amount of time. So go back to what I said in the first few minutes. You pop a Prozac, you pop a Zoloft, your serotonin level goes like this, but your depression doesn't go away, okay? There's changes that need to happen, and those changes can take weeks, okay? Weeks to occur, all right? So what we consider an adequate trial in the field of psychiatry, kind of, on the more aggressive end, 6 weeks. On the more conservative end, like 8 weeks. But the key is you need both. Therapeutic dose, not any dose. And that therapeutic dose needs to be 6 to 8 weeks on that dose. All right. So let me give you 2 examples of what I kind of run into a lot as a psychiatrist. I get people referred to me, or kind of unhappy patients will come to me saying this isn't working, and I'll ask them, like, what's going on? Tell me what you've been taking. For example, let's just pick on Lexapro. Lexapro, the therapeutic range is 10 to 20 milligrams. 10 to 20. That's the therapeutic range. I'm going to give you a couple of case examples. One example, this is very common, I'm not making this up. A patient will come to me and say, Dr. Kim, I've been on this Lexapro for 1 year. Doesn't work, hasn't touched me at all. I say, what dose are you on? They say 5 milligrams. And again, I'm not saying there aren't people out there who might get better on 5, but then when I tell them, I say, look, do you know 5 milligrams is actually not therapeutic for most adults. You need to be on 10 to 20. And they kind of give me a blank stare, and they were shocked that they were taking a sub-therapeutic or under the therapeutic range for that long. All right. Scenario number 2, someone comes to me, I say, okay, what have you been taking? What's going on? We agree the diagnosis is right. And they say, I'm on Lexapro. And I go, what dose? They say 20. I go, okay, you're on the maximum dose. You're on the maximum dose of Lexapro. So unlike the first case, this person's not being underdosed. I say, how long have you been on that maximum dose? They say, 2 years, Dr. Kim. I'm not making this up. Some people say, I say, so you've been taking this for 2 years. Have you felt any better on this? They go, no. And I'm like, why are you still taking it after 2 years long? And they say, well, I don't know. I just show up and I get it refilled and I just keep taking it. No one's told me to change it. I go, okay. I say, did you know that you're on the maximum dose? So you're not being underdosed. If it was going to work for you, it should have worked in a month and a half to 2 months, where you should have noticed a difference. And then again, their jaw drops, they're kind of shocked. I say, look, after that 2-month period, if you're not noticing any benefit, you either have to add something to it, or you got to get off that and switch to something else and kind of move on. All right. So I know that was kind of long, but those are huge points. The dose needs to be therapeutic for most people, okay? There are certain scenarios where it's actually recommended you're under that dose, like if you're elderly, if you have certain medical conditions where your livers and your kidneys are not processing things as efficiently. But in general, if you are healthy and don't have those specific medical issues, you're not in the elderly population or a child, most adults in general are going to need the average therapeutic dose range, okay? And for an adequate amount of time, like 6 to 8 weeks, all right? So let's move on now to side effects, all right? So what are some of the side effects and adverse effects that, you are kind of going to expect? And we're not going to laundry list the fine print of like 500, but the most common ones. We're going to focus on the most common ones today to make this relevant to you. Number one, and I'm going to start off with this, is sexual side effects. Yes, I know. Unfortunate, I know. Sexual side effects are one of the most common side effects of these SSRIs and SNRIs. Here's the tricky part, okay? Depression itself can decrease your sex drive, okay? It can decrease your libido. So you got to track and you got to look back and say, was I already having some decreased libido and changes in my sex life because of my depression, all right? And then see what happened when you started taking these antidepressants. Did it get worse? Okay, did it get worse? Then yeah, then it probably had something to do with it. Or I didn't, I had sadness, I had concentration problems, sleep problems, whatever. But, I didn't have problems in my sex life. I started on my antidepressants and then I have got a bunch of sexual side effects. Then yeah, then you are probably someone who gets it. It's important to talk about this because this is very common, all right? This is one of the most common side effects. And this is one of the top reasons that men and women will say, I want to stop my antidepressants, or they stop it by themselves and they never tell their doctor, all right? So it's important to have this conversation, and it's important to know this because I have a lot of patients where their prescriber never explained this to them, all right? And then the patients will freak out. Like men will say, what's wrong with me, all right? Do I need Viagra or Cialis? Is my testosterone level low? I need to go get my testosterone levels checked. Women will freak out and say, do I need my hormone levels checked? What's going on? And literally it could have just been a conversation just saying like, look, you have to be aware that you may get some sexual side effects. Fortunately, these are temporary. Look, you're going to go online, Like, God, sometimes I can't stand Reddit. Reddit is cool for some things. Reddit is crazy for others. If you go on Reddit, you go on all these blogs, you're going to read all these horror stories of people saying you're going to have permanent sexual side effects the rest of your life. Never take antidepressants. Okay, that is not the case. All right, that is not the case. I'm not trying to negate somebody's personal experience, because look, maybe there are outliers, all right, who it takes longer for them to have the sexual side effects go away. And I'm not trying to negate their experience, but in general, for the vast majority of patients, these side effects occur when this is in your system, all right? And when they wash out, eventually these side effects or these sexual side effects go away. You also have to realize some of these antidepressants stay in your body longer than others, okay? Like if I took Paxil, in the span of a week, when I'm done taking it or my doctor has tapered me down gradually and I'm off of it, it's going to be out of my system in a few days, if not a week. Prozac, even if I stop Prozac cold turkey, 5 weeks later, you can still detect it in your system, okay? And a lot of the people that are, writing some of these things on their blogs, like, when they kind of are asked, what were you taking? A lot of them will say Prozac, and they'll say, well, what happened 3 months later? And they'll say, yeah, these side effects kind of went away. So again, I'm not saying there isn't anyone who's had lingering side effects with sexual side effects, maybe as an outlier, but in general, for most people, this is a temporary side effect. And when these are washed out of you and you stop these meds, they will resolve, all right? The next set of side effects that's probably most common are GI issues, so stomach issues, intestinal issues. You might get nausea, stomach upset, and it really depends. You can get loose stools and diarrhea for some. Certain antidepressants will cause constipation. When it comes to the nausea and the loose stools and the diarrhea, again, for most people, the worst of it will be the first couple of weeks, because although we're trying to target using serotonin here, our stomach and our intestines also have serotonin receptors, and they get irritated by these medications. Luckily, our body is smart, and our body tries to maintain balance, and eventually your intestines and it will say, like, I want to desensitize myself to this, and they pull away some of those receptors, but that takes time. I will say there's still about 1 in 5 people, who even after that break-in period will say, I'm still pretty nauseous, I'm still having pretty bad diarrhea. And if that's the case, that particular antidepressant may not be for you, and you have to talk to your prescriber about what are the other options, all right? Other ones could be kind of temporary headaches that can happen, especially in the first few weeks. For some people, it may not go away, and again, you need to have a discussion. For some people, it's weird, I know, you could get drowsiness to some degree on some. They're not going to necessarily knock you out, but grogginess, drowsiness, and for others, it can actually make you a lighter sleeper, and you may notice that you wake up more often in the middle of the night. So those are some of the most common ones to talk about. Look, somebody asked a question here. I'm going to address it. They asked, are there potential side effects, since we're on the topic of side effects, are there potential side effects when when I come off these? Like, if you and your prescriber decide I'm in a good spot, and, we're going to gradually take you off of these, or, you just say, I don't want to take this anymore. Ideally, you want to do it gradually so that your body's not, going cold turkey, because my answer to that question is yes, there are possible side effects. Okay. Fortunately, they're not going to be lethal side effects. All right. Could they be uncomfortable and distressing? Yes. And this is the reason why you want to do this in coordination with your prescriber and lower your antidepressant gradually. And gradually, again, it's going to depend on the antidepressant, and it's going to depend on you. These are going to be general concepts. In general, the shorter the amount of time it takes for the levels of that antidepressant to drop, okay, so the quicker it goes out of your body, that's the better way to put it, the longer your lowering process is going to be. Okay, so tapering down, it's going to take longer, all right? The longer it takes for these drugs to wash out of your system, it's going to be pretty easy, all right? So let me give you 2 examples, all right? Like Paxil and Effexor, All right, so Paxil is paroxetine, Effexor is venlafaxine. Those, unfortunately, are notorious kind of for very difficult, withdrawal symptoms. People will say, I feel withdrawal, pretty noticeably, and it's because those kind of flush out of your system pretty quickly. Okay, so the faster that drop off occurs, the harsher it feels on your body and your brain, and that's why you notice the withdrawal side effects, which we'll talk about in a second. All right. On the opposite end of the spectrum, I kind of already mentioned this, Prozac. Prozac, the generic name is fluoxetine. I already mentioned before, if you've been a regular, if you've been taking Prozac regularly and you stop cold turkey, which I said, is not a good idea, but that's the one exception. If you stop Prozac cold turkey, 5 weeks from now, if I drew your blood, you can probably still detect some traces of Prozac. So that is on the opposite end of the spectrum, where it's, not as difficult at all to get off of that, because you and your prescriber can aggressively kind of get you off very quickly, because even when you stop taking it, it's still in your system for like a month. Okay, so it's almost like your body is kind of self-tapering yourself off of Prozac. Someone just chatted. Yeah, someone mentioned that it seems like they can relate that they had some withdrawal from Effexor, and that's so point proven. It's people out there know what I'm talking about. So the faster it is for these drugs to drop off in your system with the levels, the harsher it's going to be. So what are these things? What are these potential side effects from antidepressant withdrawal, from SSRIs and SNRIs? The best I can kind of describe it, to keep it short and sweet and simple, is it's a combination of it feels like you just got hit with the flu, like a bad case of the flu. And a lot of my patients like using this term, brain zaps. Okay, so I know that's not a scientific, medical or technical term. So let me explain. So some of the withdrawal could be just you feel tired and sluggish, fatigue, just kind of out of it. You might have muscle aches. All right. You can have stomach issues like nausea, stomach upset, diarrhea, headaches, sleep disturbances. So all of the above. And like I said, it kind of feels like you just kind of under the weather. It kind of feels like the flu. All right. But you can also get kind of this nerve-related withdrawal symptom. Okay. And I kind of use that term brain zaps because it's probably one of the most popular terms my patients have used to describe it. But patients describe kind of that, that sensation you get when you kind of like fall asleep on your arm, you slept on your arm funny. It's kind of that numb pins and needles feeling. Imagine a slightly more, uncomfortable kind of, pins and needles kind of zapping feeling, kind of shooting down, from the head, down the back of the neck, down your shoulders to your arms. So a lot of patients will describe that. They'll use the term, like I said, brain zaps, or kind of like nerve-related shooting kind of sensations and pains that will happen temporarily. But again, keyword is temporarily. But yes, to answer one of the user's questions, you can get withdrawal effects. This is why I always recommend you talk to your prescriber, figure out the timeline of how you're going to come off of it, to minimize experiencing this. And if you plan it out right, a lot of people don't experience a thing, and some people, they might feel minimal symptoms, but you want to try to plan it out to do this. And look, again, all right, you can go online right now. Go Google it right now. All right, you're going to Google antidepressant withdrawal. All right, you are going to find these like horror articles. All right, people that just go this, antidepressant withdrawal, like you're going to die from it. It's the worst thing in the world. Look, I'm not trying to downplay it. It can be very uncomfortable. It can be very distressing. And let's say you're not in a good place. You're depressed, you're anxious. And then on top of it, you're adding antidepressant withdrawal. That sucks. Freaking sucks, right? You don't want that to happen. And it could be very uncomfortable. It could be very distressing. But look, some of these articles go way overboard. And I'm going to be blunt. I'm going to call them out on it, okay? That's not science, all right? And that's, there's people who have an agenda, okay? Whether it's they're anti-pharmacy, they're anti-psychiatry, or honestly, there's even physicians who are writing a lot of these articles, and I'm sorry, they're kind of attention hounds, and they want publications, and they want to be publicized. And there's a couple out there that are notorious that are just trying to make headlines, where research and the clinical experience of the vast majority of psychiatrists will tell you otherwise, that, again, antidepressant withdrawal is real. It is real, and it's something that I plan out with my patients all the time. But let me tell you this. What is a huge common scenario that happens with many people, and maybe some of you out there can relate? You're like, I don't want to be on this anymore, whatever. Like, I don't like this. I'm having bad side effects. I forgot. I'm feeling better. I don't like my prescriber. They suck. I don't like my doctor. I don't like my primary care doctor, my psychiatrist, my nurse practitioner, whatever. I have so many patients who just stop. And then, like, when I check in with them, I'm like, yo, Mr. Smith, Mrs. Smith, I haven't heard from you in 6 months. You missed your appointment. What's up? And then they're like, oh, I just didn't want to take meds anymore. It's not my thing. I'm going to focus on other stuff. And then I'll say, well, are you okay? Like, you didn't even plan out, like, stopping with them. Oh yeah, I'm fine. Like, trust me, there are tons of people out there. I don't recommend that because, like I said, they're the fortunate ones who don't go through withdrawal. Like, I want to plan out coming off of it and coordinate that with each of my patients. But it's just to illustrate to you, like, how many people in your life do you know like that? And they're just like, whatever, I forgot, I don't care, I didn't feel like it. So, okay, I know that's not scientific, but that's just common sense, and I'm telling you. So it is true. It is something you have to watch out for, plan out with your prescribers. Man, this is why, like, the internet is great in some cases. It's a great technology, speed of information. I love how it connects us. But man, there's so much crap. There's so much crap out there. And it's like, you don't even know who's writing these things. You don't know what their credentials are, who they are. And all you have to be is popular, and then your information, your misinformation gets disseminated everywhere. It drives me crazy. It drives me crazy. Anyways, okay, off my soapbox. Let's wrap it up. Like, I blab so much. Oh, I blab so much. And we're getting now to past the half-hour mark. So I want to wrap it up in the next, like, 5 minutes, 10 minutes, 5 minutes. Let's say 5 minutes, because then we can do more interactive Q&A, okay? So let's talk about realistic expectations. Realistic expectations. So if I have the diagnosis of major depressive disorder, clinical depression, and I am prescribed this, I'm taking a therapeutic dose, I'm taking it for the right amount of time, at least minimum 6 to 8 weeks. I'm not missing doses, skipping them. I'm not having terrible side effects. I'm having mild or, tolerable effects. I'm consistent. What are my chances, Dr. Kim? All right. So I'm going to give you the realistic stats, and if you're a glass half full person, you might say that's not bad. If you're a glass half empty person, you might say this is kind of sobering, but I'm here to tell you the truth. Okay. So in terms of success rates, let's say it's your first time trying an antidepressant that you can tolerate without bad side effects. Okay. And you took the right therapeutic dose for 6 to 8 weeks. The chance that you on your first try will say, my depressive episode is gone. Okay. I'm feeling like my usual self. I'm back to my baseline. All right. Chances of that are like 1 in 3. Okay. About like 33%, give or take a few percentage points, chance that you'll say on your first adequate trial of an antidepressant, man, this is like night and day. I'm back to my usual baseline. Okay. 1 out of 3 chance. But close to half, upper 40-some%, close to 50% will say, maybe I'm not back to my baseline and my depression is gone, but I feel much better. So close to half the patients who take this on their first try will say, I had a positive response. Okay. Remission is when, like, my depression is gone or damn close to gone. All right. I'm either at my baseline or pretty damn close. Response is, I'm not at my baseline, but you know what? I'm functioning a lot better. Like, my mood is a lot better. My symptoms are more than halfway better. My school life, my work life, my personal life, functioning much better, but still there's kind of this gap. I'm not quite at my baseline. That's what we call positive response. So first attempt, 1 out of 3 remission, close to 1/2 will say, not remission, but much better. Okay. So what next? For those that don't feel like they're back at their baseline or not better at all, you have the options of either adding something to that antidepressant and taking like a combination, or you may just have your prescriber and you decide you're going to switch to something new. Statistically speaking, after multiple attempts, so multiple tries, okay, if the first one was not successful, after multiple tries, About 40 some percent, 48%, give or take. Okay, so mid 40% range will achieve remission. Like, I'm back to my baseline. Close to 2/3 will say, my depression's not gone, but I am much better. Okay, so after multiple attempts, still slightly less than half will say, I've achieved remission. 2/3 will say, I feel much better. All right. So think about that. Like I said, that's kind of what I meant. If you're a glass half full, you say, hey, that's not too bad. All right. Close to half, close to remission, 2/3 much better. But if you're a glass half empty person, you're gonna say, hey, like after all those attempts, after not just one, but multiple treatment attempts, combinations, half the people still, aren't feeling like their depression is gone. My answer is yeah. This is why meds are not a silver bullet. Okay. Meds are not a silver bullet. All right. I am a psychiatrist. I'm an MD. Unfortunately, in this country, psychiatrists have become kind of like pill pushers instead of doing both the therapy, and the prescribing, unless you see a cash-only, psychiatrist who charges you like $300, $400 an hour, which 95% of the country can't afford. But, unfortunately, psychiatrists have just become prescribers. And this is coming from a prescriber. I work in clinical research. You would think I'd be like a pill pusher just telling you like, oh, this is the best thing in the world. No, these are the sobering realities. Meds and what they can do, they're a useful tool. And when you need them and when they're needed and you use them appropriately, look, I'm all for that. When you need help and someone is in a bad situation, it's like you throw the kitchen sink at them, right? You got to do whatever you can to get them to feel better, all right, to function better. But they have limitations, okay? They're not going to work for everybody. They're going to have side effects. And even when you use them appropriately, like we outlined today, you still may not even get full remission. You may only get a partial response. So you have to be realistic in your approach. And this is why I always, always, always recommend, if possible, and if you have access and you can afford it, okay, is whether it's therapy, support groups, whatever you can do to kind of supplement this, all right? Because the side effect for that is time and cost, financial cost, but you're not ingesting something and putting something in your body. So a balanced approach, really, that's what we have to do in America more so, all right? Here's another, thing that a lot of people ask. So I get better, right? I'm good. Am I at risk of kind of sliding back? And when is that risk the highest? The risk of sliding back, even after you got better, okay, whether you got better with therapy, whether you got better with medications like we talked about today, the risk of kind of sliding back and relapsing into your next wave or episode of depression, unfortunately, for the people who even reach remission, close to half of them will kind of relapse and have another episode of depression within the first year. Within the first year of them kind of recovering, that's kind of the highest risk period, that 1 year period after you feel better. We have theories why. We're not going to dive into that today. We have theories of why, but that's kind of like a vulnerable period, that first year after you kind of achieve feeling better. That's the high risk period where you may fall back and kind of slide back into another episode of depression. And that's why, again, I emphasize whatever it is, lifestyle changes, trying to decrease your stressors, therapy, whatever you can do in addition to the medicine, hopefully that will enhance the chances you will not have a relapse, too soon or ever, hopefully. All right. So look, I know there's kind of a lot of information. Like I said, I didn't want to get too focused on the chemistry of it, but kind of those practical tips, all right, like timelines, rates of success, side effects to expect. And I will try to, in the upcoming weeks, do a few more of these live streams where we'll focus on some of the other treatment options. Okay, there are non-medicinal options out there. Okay, I'm not even just talking about therapy, but there's something called TMS, which is transcranial magnetic stimulation, ECT or electroconvulsive therapy. There are other categories of meds besides SSRIs and SNRIs, like people sometimes use low doses of antipsychotics. And I know that sounds scary because when you hear the word antipsychotic, you think of schizophrenia, you think of psychosis, you think of bipolar disorder, but there are a few of them in very low doses that are used to kind of supplement antidepressants. So I will try my best to find some spare time to do a few more of these impromptu live streams. Try to put it up on a schedule telling when the live stream is going to happen. I'll be better about that hopefully in the future. To just talk about some of these other options, because I think some people aren't even aware there are these other options besides kind of your standard Prozacs and your Zolofts of the world. All right. So again, Dr. Andrew Kim, a lot of the concepts we talked about, they're in some of the other videos in my video playlist. So please like this, subscribe. I'll leave this up for a little bit on my playlist if you didn't have a chance to watch the whole thing.